afternoon and welcome back to our last session of the day. Our speaker for this session is Dr. Elise Berlin. Dr. Berlin is going to be presenting her topic, Updates on Adolescent Contraception, Counseling, and Contraceptive Initiation. So Dr. Berlin will be taking questions throughout the session. Please use aapcme3.cnf.io to submit questions or to upvote someone else's question. Be sure to have selected this seminar on the aapcme3.cnf.io site before submitting your question. One aspect of today's session that will be a little bit unique is Dr. Berlin will also be asking some audience response questions. So in order to participate, you will again use the aapcme3.cnf.io site. When an audience response question is live, it will automatically show you this site, will show you on your aapcme3.cnf.io site, and you'll have 10 seconds to respond. I think this will probably make more sense when the slide comes up. So without further ado, thank you for being with us today, Dr. Berlin, and anxious to hear about updates in adolescent contraception, counseling, and initiation.
Excellent. Good afternoon, everybody. I am so excited to speak with you. I know this is the last, I understand this is the last session of the day, so thank you for being here. I'm an adolescent medicine pediatrician. I work and practice in Columbus, Ohio. I work at Nationwide Children's Hospital, and I'm the founder and the director of our contraception care clinic here, which is called BC for Teens. And I'm on faculty as an associate professor of pediatrics at The Ohio State University. So without further ado, I'm really excited to get into our talk. So I do want to share the disclosures that I have. That's really important to me and to the AAP. I do receive research support from Merck. I'm not paid directly, but I get some salary support. I have been a consultant on several occasions for both Merck and Bayer, and I'm also a Nexplanon clinical trainer, and so I receive honoraria from Merck for that activity. Here are the objectives of the talk. I do want to make this a very practical talk for you. The first objective is that when we're done with the session today, that you're going to feel able to counsel your adolescent patients on the available prescription contraceptives using a patient-centered contraceptive counseling approach. And we'll go through what I mean by that. Number two is how to be reasonably certain an adolescent is not pregnant, and that's an important skill that's part of contraception care. Number three is to really support you in locating easy-to-use resources to help screen for medical contraindications to contraceptive use. And then finally, that you are really able to initiate the requested or an alternative or bridging contraceptive method. And we'll talk about what the language around bridging methods means. So this is kind of our more human level roadmap of the talk. First of all, I want to talk about and get some input from you about where we're at, and then what changes has the COVID environment kind of brought upon us. Number three is a really something I've been having a lot of fun with lately, which is really sharing some new contraceptive products and label changes to you. After that, we're going to get into the kind of the meat of the matter and talk about where the family planning world is with regards to updates in contraception counseling. The second to last bullet is what I call the basic important stuff. And then finally, we do have some slides, and you should be able to access these after the talk with some reference materials that I either recommend or endorse as being good references for you. So where are we at? So we are going to hear from you in just a little bit, but I wanted to share with you, thoughts that I have and thoughts that I hear from my general pediatrician colleagues. So this may be you. You are likely to have a busy practice. You may not have enough time to see your adolescent patients and do the job that you want to do for them. You might not see that many teens and then feel a little bit out of practice when you see them. You may be uncertain about adolescent consent and confidentiality, whether that refers to the United States, your state, your region of practice, the policy at the institution you work at. You might feel or know that you don't know enough about what's new in contraception. You don't remember enough to feel comfortable prescribing birth control, and you might not be sure where to find accurate information about contraindications, and so you were worried about prescribing contraceptives. So if this is you, please consider yourself welcome to this talk, and you are not alone. You are not alone. These are the common themes among general pediatricians and general providers on adolescent healthcare and contraception. And I wanted to share with you a series of interviews that my team led with general pediatricians at my institution. We did a research project about 8-9 years ago now, and we asked our general pediatrician colleagues about barriers to contraception care. And I did want to share with you what they said because I found it so interesting. It wasn't what I thought. So from one of our participants, we had plain old discomfort. So this participant, number 22, said, I think pediatricians in general do pediatrics because they don't want to deal with adult issues, of which sex is one. And that's why every time a teenager comes in, everyone in the room groans. So I don't know if this is you or someone that you know of. And this is really kind of what I thought we were going to get, a lot of this. But to be honest, these types of responses were actually the minority response. And people overwhelmingly did not feel this way. But there is this kind of probably more of a curmudgeon about adolescent healthcare. So the next one is not enough time. So we have a system that basically asks the physicians to see patients very quickly. And part of our reward system is based on how quickly we see our patients. So adding a teen to the mix, those physicians are saying, I'm not going to address this issue. I'm going to send you to teen clinic for LARCs, as an example. We'll address it later. Many young people don't have that immediate access, so many of the kids don't go for the referrals when they're referred out. The infrastructure does not allow teens to have their needs met right in their communities. Operational challenges. This is participant 8. So I think everybody wants to do a good job for our families, but we don't really have the tools or the time to do that always. I think it's frustrating for everybody. Concerns about confidentiality. Participant 3 said, one of the biggest things that would help me is knowing exactly how to get it to the patient without billing for it or having it in their medical record. I need to know how to protect the patient's confidentiality. Outdated knowledge. I forgot to write the participant number. I have no experience with IUDs. Zero, zippo, zilch. I remember in the olden days that they were not recommended for people who have not had a baby yet. And I don't know anything to say about the new ones, whether it's okay or not, and I have no ideas about it. And then the person chuckled. Nor do I want any ideas about it. Not going there. Fears of adverse events. And these are themes, the ones that I've culled are really themes that emerged across the interviews. So I'm just not comfortable. I mean, I understand the data that these are safe, but I just feel like my kids are young and I feel like, wow, I don't feel comfortable with it. And this was about IUDs. So I understand the evidence says otherwise. I get that. But my personal feeling, I'm just not going to discuss it. So this respondent, because of their own discomfort, wasn't going to discuss IUDs with her patients or his patients. So many barriers, right, that adolescents have when they are may have the opportunity to seek confidential or otherwise, reproductive health care from their pediatrician. And then to throw in the mix, we've got COVID. And with our adolescents, what are we seeing with COVID? So in where I live, we have seen for sure reduced office visits and well visits for adolescent patients. and then an increased focus on mental health disorders and concerns and social and school issues. So that has really been a challenge because we're not seeing young people and not having the opportunity to have these conversations with them. Introduction of telehealth. We talked about that on the Q&A earlier. There has been so much that we have learned, and there have been so many opportunities with telehealth, but with teenagers, there are really challenges with confidentiality and privacy in teenagers. And then these questions about, well, how do we prescribe birth control by telehealth? And that is, unless we have time for questions, that's gonna be beyond the scope of this talk, but really a barrier, right? To like, how do we do this safely? So with that being said, I have highlighted some of the themes that have emerged in some studies, but I wanted to get a chance to hear from you about what challenges you face providing sexual and reproductive health care to teens. So please access the Conference IO system and type in what challenges you face providing sexual and reproductive health care to teens. Time constraints, yeah. It's being upvoted. More? We'd love to hear your thoughts. Okay. So confidentiality, I'm not comfortable with the options and which one to use. I don't have enough information about how to start one. Insurance, time constraints, confidentiality, absolutely. Parent needed to pick up prescription. All right, wow. This is really wonderful. Thank you everybody for chiming in. Are there any other ideas or thoughts out there you'd like to share? All right, really, so this is amazing, and I'm so grateful that you wrote this. So time constraints being probably the top issue. I'm not comfortable with the options in which to use, top issue. Confidentiality, a top issue. So there are things that are absolutely beyond what I can fix with this talk. We will hopefully, with the other pre-recorded talk I provided, we do go over kind of options, especially oral contraceptive options in which to use. We are not talking about confidentiality. However, what I would like to really help you with is information about how to start one. That's something that we'll be able to do today. And hopefully you can also access the resources to learn about the options too. Okay, one pill doesn't work, what would be the next option? And again, we have that in the pre-recorded contraception talk. All right, so thank you so much. We're gonna have more options in the talk to do Q&A, and we do have some time, so if there are any of these themes that we do not address directly during the slides, please ask them in the Q&A, and I will give you as much content as I can. All right, this next part is really to share with you some really relevant contraceptive updates. They may or may not be useful to your practice, but they're news and new in the world of contraception. So I thought it'd be nice to share those with you. The one that I'm probably most excited to share with you that most people do not know about is Depo Sub-Q Provera. And I know I can't see you right now, and I wish that this were live. there is a formulation of Depo-Provera. Most of us are very familiar with intramuscular Depo-Provera. That's a 150 milligram dose of medroxyprogesterone acetate. The Depo Sub-Q Provera is a low-dose subcutaneous formulation that is a pre-filled syringe. The product is designed to be self-injected, but it can obviously also be injected by a caregiver, a parent, a loved one, etc. The dose is lower in the Depo Sub-Q. It's 104 milligrams, but it has the equivalent effectiveness and similar side effects to the standard intramuscular formulation. So the CDC just released guidance about 4 weeks ago recommending that sub-Q Depo be available and offered to women as a contraceptive option. So this is really a great option. You can write a prescription. I think in the references, I've got a link to some teaching videos and content like that. And after the talk, if you have questions, feel free to email me directly. We have about 105 young people at Nationwide Children's who are currently, and since COVID, have been prescribed sub-Q Depo-Provera. So I think that's really a game changer, and it doesn't require a user to come to the office. All right. So another couple fun ones, and the first one is a little bit of an old one, but if you don't prescribe contraceptives very much, you might not know that Ortho-Evra, which was the contraceptive patch, is no longer. So it has been replaced by a generic called Xulane, and this is essentially the same medication, but just a generic of Ortho-Evra, and it's called Xulane. There is another patch that just came out, and this one is called Twirla. So I'm going to share with you a couple points about Twirla, and certainly don't expect the majority of you to prescribe this. Twirla is a round patch. It has a lower exposure to estrogen compared to the Xulane. So the hope is that it has a lower clot risk compared to Xulane. A couple downfalls about Twirla is that the patients have basically tended to look like they're bleeding a little bit more with unscheduled spotting and bleeding on Twirla. And this may be because of the lower estrogen exposure. It's also looking like it's not quite as effective as the other combination hormonal contraceptive products for women at greater BMIs. So we do see a fall off in efficacy in the overweight zone, and really it's actually contraindicated for women with a BMI greater than 30. So that's new for a combination hormonal contraceptive product to have that contraindication. And there's also a little bit of concern about blood clots in the BMI over 30. So, but I just wanted you to know that there's a new patch out there. You may be familiar with the current vaginal ring that's called NuvaRing, and this is actually a great product. Users tend to have less bleeding than with a combination hormonal contraceptive pill. Lots of middle and early adolescents don't feel too comfortable inserting the NuvaRing, but I have a handful of older adolescent patients who love this and young adults. Just a little practical pearl is that NuvaRing can be placed inside a tampon applicator. So you can buy like a Tampax tampon, and with a plastic applicator, take out the tampon, scrunch up the NuvaRing, and put it in the tampon applicator. And a woman can actually use the tampon applicator to insert the NuvaRing. So that's a little practice pearl for folks who might like to do that. So the contraceptive update is there is a product called Anovera, which is another contraceptive ring. The cool thing about this ring is actually just one ring that lasts the whole year. So for people who live in states where you can prescribe for a whole year, you can prescribe Anovera, and she doesn't have to go back to the pharmacy for the whole rest of the year and get refills. She doesn't have to keep it in the refrigerator. And essentially, she's going to use it like the NuvaRing. The product label has women insert for 21 days and then have it out for 7 days. It comes with a little case, And so she can rinse it and take it out for 7 days for a hormone-free interval. And both of these products can be removed for about 2 hours during sex if they need to, and then rinsed off and put back in. So those are some fun contraceptive product updates. I've got a couple more. Slind is probably the one I'm using the most. And the reason I wanted to share with you about Slind is because this is a progestin-only pill. This is the first progestin-only pill that we've had that's new in probably several decades. It's made of drospirenone, which is a progestin. It's a 4 milligram dose. And this pill actually comes packaged as 24 active pills and 4 placebos. The half-life is about 30 hours, and so the dosing interval is much more flexible than the current norethindrone mini pill. So it has more flexibility, it suppresses ovulation, and it's being increasingly covered by the insurance company. So I do want to encourage you to think about Slind when you're prescribing contraception for a patient who needs a progestin-only option. This is a nice pill to know about now. It has like the worst name ever, I think, but I think it's a great option to know about. The main counseling I would tell you about this pill is to counsel your patients that they may have irregular bleeding, but that's not different than any other progestin method that you're going to counsel them about. A couple label updates. So Mirena and Liletta, which are both 52 milligram levonorgestrel IUDs, are both now approved for 6 years of use. Yeah, so this is a great update in terms of longevity of a device that many girls and women already have in their body. And I wanted to remind you that nulliparity is not in the FDA label at all for these products. So there is no longer any preference for or indication for users who have already been pregnant or had a baby in any of the IUDs. The most recent kind of news and breaking update with regards to IUDs has to do with emergency contraception. So you may be aware that the copper IUD is the most effective emergency contraceptive. What we have learned in the last several months, and Dave Turok, who's in Utah, did this elegant trial and demonstrated that the 52 milligram levonorgestrel IUD, and they actually used Liletta in the trial, is non-inferior to the copper IUD for emergency contraception. So this is a big, I think, a big game changer for women who need a very effective emergency contraceptive and want that, but don't want to start a copper IUD, because we know that the hormonal IUDs are so much more popular. So I think you'll be seeing more come out about the hormonal IUDs as emergency contraceptives. All right. Another thing I wanted to share with you is that Nexplanon, so you may hopefully be aware that this is a hormonal method. It's an implant that has a label for 3 years of use. It is currently undergoing clinical trials to extend to 5 years of use. So over time, I suspect that we're going to see that the label is going to change for Nexplanon to 4 and to 5 years. A couple fun, I have two fun ones. Phexxi. So there was actually just an article 2 nights ago or 2 days ago in the New York Times about Phexxi. This is a new contraceptive gel. And the way Phexxi works, it's not a spermicide. It works by lowering the vaginal pH and effectively kind of immobilizing the sperm. The active ingredients are lactic acid, citric acid, and potassium citrate. And it comes in a pre-filled applicator like you can see in the image. And it's actually found to be 86% effective with typical use, which is higher than typical use of condoms. You can also use it with a condom or with any other contraceptive product, a hormonal contraceptive product. But I think it's really a nice option for patients who don't want hormones at all. This is a prescription option, so something to be aware of. The final one I have is called Natural Cycles. So this is the first ever like medical device app, and it's actually FDA approved, and it's approved in the EU. This requires that a user take her temperature with like a Bluetooth thermometer, which zoops the information to the program and to the complex algorithm. And it's been found to be 93% effective with typical use. So really comparable to combination hormonal contraceptives, which is really pretty impressive. No prescription is needed. A person can just go to like the app store or wherever she's going to get apps. It's FSA and HSA eligible, and the prices are there. The most important thing for you to know, though, is this has not been tested on adolescents. I emailed with the medical director of the company after my slides were due. Because I looked at the clinical trials and I saw the mean age was 29 of the users. So it's actually FDA approved for 18 and up, but you may have patients who are eligible. And you just might find this useful to know about. So again, it's called Natural Cycles, and it's essentially a fertility app and a contraceptive app. And it also has a product, that's the inverse of their contraceptive product, which is a fertility product. All right. So with that, we're going to take a little break for questions. So we have some time. Please put in any burning questions you have. This is not a LARC specific focus talk. So if you have any questions about IUDs, implants, any of the content we've talked about, please share.
So Dr. Berlin, here's a few questions that have come in. So first is, how do you maintain patient confidentiality, specifically like with the insurance bill for STI testing? Kind of contraceptive management if the patient's not ready to disclose to their family.
Oh man, you guys. So this is the problem, that if someone is coming in with private insurance, this is something that's very difficult to get around. And right now with the Affordable Care Act, young people could stay on their parents' insurance till they're 26. So this is not even like a minor confidentiality issue. This is a young person issue. There is not much. Those of us who are, some states, I think, have introduced legislation to protect this information, but most of us probably don't live in those states. So I think that's something when you're counseling your patients, is to be aware of whatever issues they have with confidentiality. If they really do need confidentiality and you cannot provide that for them, I encourage you to just be familiar with your local resources are, whether it's a federally qualified health center, Planned Parenthood, public health department, etc., where they can get confidential care. But that insurance issue for STIs, for contraception, very difficult. If your patients have Medicaid, in many places that the EOB does not include, doesn't go out. So if they have Medicaid, you're usually okay with that. But this is a challenge, and it's usually state specific and institution specific.
Next question is for Phexxi. If it lowers the vaginal pH, does it cause any kind of long-term complications, i.e. kind of change in the microbiome?
So, very good question. So if you look at the Phexxi website, I've not prescribed it myself because it's really that new. The side effects include like vaginal discharge, bacterial vaginosis, yeast infections. So I do, and I don't recall the incidence percentage of those, but it does look like those type of vaginal concerns have been reported, certainly by clinical trial participants. I don't know, but I don't suspect it causes, well, I'm gonna just stop and say we don't know about the microbiome and Phexxi, but those concerns have been raised.
Okay. So this is not a contraceptive question, but at what age is tampons okay to use? Any special precautions or instructions that need to be given?
This is great. As soon as a patient is menstruating, she can use a tampon. I have young patients who are swimmers, who are active, who like took to tampons like right away, and I have other patients who just aren't able to insert them even though there's not a biological or kind of hymenal issue. You know, my recommendation for patients who are interested in using tampons is to start with the smallest one, like the the Junior Slim or whatever kind of little itty bitty tampon it's going to be. It's nice if they try when they're on their period because it's going to be a little bit more lubricated, but she can try off her period, but it's really important to put some lubricant on the tampon, but no young age.
When are progestin-only pills recommended?
Oh gosh, okay. I may save this one for later on, but I will give you some very common contraindications to estrogen would be a migraine with aura. That's probably the most common. A lot of practicing physicians and providers have forgotten that or don't know that. So if a woman has a migraine with aura, it is contraindicated at the highest level for her to use an estrogen-containing product. And that's the most common thing that we see. So those women can use any progestin-only contraceptive just fine.
And then how can an IUD be used for emergency contraception since the patient has to go to a GYN and general pediatrics offices? We don't insert.
I know, yeah. So this is, I think, you know, we certainly, there are just a handful of pediatricians in the country who put in IUDs. I'm one of them. But this is not a common practice for pediatricians. I want you to know this because you certainly might be frontline providers and patients or their moms calling you about experiences of unprotected sex. If you know who the providers are in the area, whether it's adolescent medicine, OBGYN, who can place IUDs, then you may be able to help that young woman get to either one of the most effective emergency contraceptive methods and maybe a method that she's going to like to use for a long time. So really that question was just on awareness and around kind of your referral patterns.
Then a question on how do you educate a patient on the patch? We have no compliance as the patch is not sticky.
Sorry, what's the question?
The question is how do you educate a patient on the patch, and then in parentheses, we have no compliance as patch is not sticky.
So I have had some patients who just, I don't even know why, like the patch doesn't stick to their skin. I have had patients who are elite athletes and it, you know, doesn't stick on their skin. So I think if the patch doesn't stick on them, like it's not going to be a great method for them. I know some people put like tape on it and things like that. I do worry if it's not adhered well, that it's not going to be, basically the patient's not going to be absorbing the hormone. So I think if it's not sticky, not a good plan.
So question is, do you need to do a pelvic exam for prescribing all oral contraceptives?
No, this is wonderful.
It's for routine.
No. So I think one of my further slides talks about that. No pelvic exam is needed for any contraceptive except for an IUD, which is obvious that you need to do a pelvic exam. But there is no longer any recommendation or requirement about a pelvic exam. And you can imagine that it really does not need to be coupled in any way, right? So yeah, no pelvic exam.
What is a good way to explain regular periods in a girl who's getting infrequent periods?
I'm not sure. Like the value or the importance of regular periods? I don't know. I'm trying to understand that question.
Well,
maybe
move on to the next one. You know, guidelines are clear for screening for STIs among sexually active females, but not so much for males. Any thoughts about screening routinely if a male is sexually active?
Yeah, you know, there are different schools of thought on this. I think for most sexually active young men, and what we have found when we've studied it, is they're really not going to test positive for routine screening. And that's part of the reason it's not recommended. I think if you have a young male who engages in higher risk sexual behavior, more frequent numbers of partners, anal sex, if you're seeing that young person in a setting where you have a higher prevalence of infections, such as adolescent medicine, juvenile justice system, then maybe screen all those folks. But I think out in private practice, I don't, unless you're doing a universal screening protocol, which is kind of a separate topic, I don't recommend universally screening young men.
We've got a few more questions, Dr. Berlin. Do you want to take these now?
I think we're going to have to, I think we should, in the interest of getting through the slides, because I don't want to shortchange anybody on that, let's go ahead and get through the slides.
We'll come back to those. Thank you.
All right. So welcome back to the slides, everybody. And see if I can advance it. 1 second. Okay. So I really want to shift gears a little bit, and this is something that I have been thinking about a lot over the last several years. And I hope that I'm going to be able to communicate my thoughts on this well. The world has become more aware of injustices to persons of color and other marginalized and disempowered folks. And we are aware of both historical and contemporary injustices that have been perpetuated. These include rape of enslaved and oppressed persons, family separation at slave auctions and borders in our contemporary times, forced sterilization, as an example in the eugenics movement of the early 1900s, coercive contraceptive practices. And these we have more contemporary examples of, let's say, incentivizing LARC products or making those more available than other products. Practices such as requiring contraception care for substance abuse treatment and or differential management in the justice system are examples of coercive contraceptive practices. And then in 2020, there were some reports of hysterectomies performed without consent among persons that were coming to the US as immigrants or seeking asylum. So we have a history of coercive and unjust practices perpetuated against women, in particular marginalized and persons of color in this country. And this has really informed the thinking around family planning provision to make sure and to highlight the risks that we have in perpetuating coercive practices and unjust practices. There's a couple quotes I'm going to share with you from a paper that was published a couple years ago. And you may know, those of you in the audience, that there has been really a shift in thinking around IUDs and implants in the last decade. And this was because there was a large, primarily because there was a very influential research project called the Contraceptive Choice Project that came out of St. Louis that really demonstrated that women are interested in IUDs and implants if we remove knowledge barriers and make them available at the point of care and make them available without financial barriers. So, you know, the world, you know, OBGYN, adolescent medicine, it's trickled down to peds, has really embraced IUDs and implants as a primary option for women, including young people. But there has been, I think, the pendulum, swung a bit too far. And I want to share with you a couple quotes from patients who felt that their providers were not being fair in their presentation of contraceptive options. So this is Carla. She's a 21-year-old mother, and she described feeling as if her providers were salespeople. They kind of like, you know, talk you into it, like they're selling you a bar of soap. The soap will last and it'll smell good. But you can feel here that she kind of sensed that she was being sold something. We don't want our patients to feel like that. This next one is Marissa. She's a 21-year-old mother, and she recalled receiving more information about IUDs than other methods during a postpartum visit, and the flat affect of her provider when describing the ring and other methods. In contrast, she recalled her provider speaking with animation and offering more information about IUDs, noting she kind of seemed more brighter about that one, the IUD. She was kind of like more smiley. So I am, you know, this is probably could be said about me. And these are the kind of comments that I have really tried to learn from and to modify my practice so that I am being very fair about all the options and really listening to my patients. But I wanted to share with you that that the world is really kind of moving away from thinking about IUDs and implants as the answer, and the availability of those methods as the ultimate answer for all women. And we'll kind of get into that a little bit more. I wanted to share with you a framework which has emerged and become more in the kind of common conversation. But this framework is called reproductive justice. So reproductive justice framework was launched by a group of women of color representing African American, Latin American, Native American, and Asian American women in 1997. And since then, the ideas have been kind of amplified and spread around. The idea with reproductive justice framework is that all people have the right to bodily autonomy, to have children, to not have children, and parent the children they have in safe and sustainable communities. This really hits me as a pediatrician because we care a lot about how our patients grow up, what kind of communities they grow up in, and also the communities that their children are going to live in. So, you know, this framework has really challenged a lot of us to be, I think, much more fair and balanced in how we present contraceptive options, and also really really highlighting the opportunity that we have to listen to our patients and hear about what they want. So the next set of slides I'm going to share with you are going to talk a little bit more about some new frameworks for listening to our patients and some questions that might help you do that. So as I mentioned, there is kind of as part of this consideration of reproductive justice, as well as the history of coercive practices in the US, there really is attention to shared decision-making now in contraception care, as well as all kind of aspects of reproductive health care. There is an explicit focus on non-coercion in many policy statements and guidelines that have been published recently, and also explicitly talking about removal at request. And that's in particular about IUDs and implants. It used to be very common for a provider to say when she was placing an IUD or implant, you know, we want you to keep this in for 6 months, to be just very explicit about that, or to say like, do you agree to have this in for 6 months? Because we don't want to take it out before. That practice and that kind of language is really discouraged now. And the thinking is really we want to make it as easy to discontinue a method as it is to start a method. And really anything less than that is potentially being coercive. And so the framework that is really encouraged is called shared decision-making. And this is probably something that you as pediatricians already just know kind of in your core. But what shared decision-making really is eliciting your patient's preferences and helping them to make decisions that are aligned with their preferences and values. I'm going to contrast that to informed choice. So informed choice is basically you give the patient a menu and they say, oh, I think I'd like an implant. And you say, okay, great, let's do an implant. Like that's really not what we want to. Directive counseling is more along the lines of, you know, I think what would really be great for you is X. So that is also not an approach that we're going to really, that is suggested as being optimal. The optimal approach is kind of in the middle of both of those. And we're going to talk about how to do that. And this is from a patient. This is language that Christine Dalen North published in Contraception in 2013 about what patients want. I think providers should be very informative about it and non-biased. Maybe not try to persuade them to go one way or the other, but maybe try to find out about their background a little bit and what their relationships are like, and maybe suggest what might work best for them, but ultimately leave the decision up to the patient. So some example wording I'm going to share with you around contraception and kind of starting those conversations. So I'm here to help you decide which birth control is right for you. What's right for you may be different than what's right for your mother, your sisters, and your cousins or your friends. The decision about starting or stopping a method is yours to make. So in my opinion, it's important that the patient understands the decision to start and stop the contraceptive is hers to make. And it's important that you as the provider understand and know that her decision for contraceptive use has been freely made. And then really that removal, for those of you who might be implant providers, at patient request is explicitly acknowledged. And so when I place an implant, I tell all my patients, if you're not happy with this, if you have a side effect concern, whatever it is, please come back, come talk to me, we'll sort it out. And if you want this out, I'm happy to take it out. So that's really different. I'm gonna let you know than kind of how we talked about these 5 years ago. So I'm going to share with you how I start my reproductive health visits. After I make a little chit chat and say hello, introduce myself, I switch and I look at the patient and I say, I'm going to tell you a couple things that are important to me about this visit today, and I want you to know, number one, you're the boss. And a lot of times they're like, what are you talking about? I'm the boss. I say, so you are the boss. Your mom or your guardian or your caregiver who's here with you today, they're your co-pilot, and they're going to help you and support you and guide you, but you're the boss. Number two, I tell them explicitly, I won't do anything to you without your consent. I think there's really a heightened consent in relationships over the last several years. And so I am explicit as well that I'm not going to do anything without their consent. And if they decline any exam or test, that is their right. I tell them if I feel strong about it, I'm going to push back a little bit, but then they can always push back. And that what's most important to me is an ongoing relationship with her. And then number three, setting the stage. And for any of you who've heard Ken Ginsberg talk, he's at CHOP and he was my mentor as a resident. He coined this phrase. But I go through 1, 2, and 3 just like this. I say, during our visit today, it's my practice to spend some time one-on-one with my patients, as long as it's okay with your parent. And then I eyeball the parent, smile, and look back at the kid. And this really does activate some HIPAA protections for that conversation when the parent steps out later. And I say what we talk about when we're alone will be private and not shared with folks outside of your healthcare team. Of course, if you're being abused, suicidal, or at risk for serious harm, I'm going to need to break confidentiality by law. And then I kind of let them sit with that. And then so I say, oh, we're going to do this later on in the visit, but first let's talk about what brings you in. So hopefully, and really this can just take a minute, you know, I've centered on the patient. She knows she's the boss. I'm not going to do anything to her without her consent, and that we're going to have some private time. All right. So moving towards identifying patient-centered reproductive goals. So one of the things that's recommended for all females of reproductive age is to understand pregnancy intention and to do reproductive life planning. And this sounds like a mouthful, but I'm going to share with you a couple easy ways to do this. And I have found this to be so valuable in my own clinical practice. Actually not assuming that the girl wants to avoid a pregnancy is really, really important. It's so important to be on the same page with your patient. And for those of you, and Dr. Gigante and I were talking just before the session about a young adolescent who was pregnant recently. So understanding the pregnancy intention of all of your patients can be really helpful. So there's a couple ways to do this, and you might be familiar with some of them. The first one that I'm going to share with you has been kind of copyrighted or trademarked as the one key question. This is the simplest way to do this. Would you like to become pregnant in the next year? So I ask all of my adolescents, and I'm seeing, so this is really works with girls and females, but the next one I'm going to share with you works with boys too. And this one you can ask a boy too and say, would you like to become a parent in the next year? Most adolescents are going to look at you and go like, oh, I don't want to get pregnant the next year. No way. And then you can say like, oh, great. I'm so glad I understand where you're at with that. The other one that I think is really nice, and Patty Kaysen, who's a nurse practitioner in California, developed this, and it's wonderful. And it has been uptaked by lots of folks. I love this one. This is why. So it is something that really gets at how important is it and what's the time. So number one, do you think you might like to have children at some point? Number 2, when do you think that might be? And number 3, how important is it to you to prevent pregnancy until then? So both of these are really brief questions that you can add into your sexual history that are going to help you understand your patient's reproductive goals. Most adolescents are going to have a negative pregnancy intention, and understanding that and knowing that is going to really help you ally with them around contraception if they're interested. You are going to have some patients, and they're more likely to be probably more older adolescents, but it can be younger adolescents, who are ambivalent about their pregnancy intention. And these are the ones to keep close, because these patients are going to have a higher risk of having a pregnancy happen. So these patients certainly might benefit from preconception care, including prenatal vitamins, etc., as well as more frequent follow-ups, and maybe figuring out what's most important to them. So after you ask these questions, and I'm going to tell you, I use more like the one key question in my practice and just say, are you interested in getting pregnant in the next year? After you hear back from them, you're just going to give a little bit of reflection. Oh, I get it. You're not interested in having children anytime soon. There you go. Or, oh, so you're interested in having kids, but it's important for you to wait for a while. These are wonderful things to actually voice in a visit. So then the next thing to do, once you understand their pregnancy intention and a little bit more about their reproductive life plan, is to extend the conversation. So for those who are ambivalent or have a negative pregnancy intention, would you like some information today about how you can prevent an unintended pregnancy? So that's one way to do it. Alternatively, would it be okay with you if we talked about some birth control options? Again, you can see that we're really centering on the patient and what the patient wants to know. So we have 3 or 4 slides, and we're going to do a little bit more conference IO action. But these are the questions I would like to know from you. What are your thoughts about this? And I've heard lots of thoughts on this, so I would love to know your thoughts. How are these approaches different than what you use now? What do you like about this? And what might be hard? So we're going to go and click through the next couple of slides to get some audience participation. So first of all, for many of you, this might be the first time you've heard talk about pregnancy intention assessment in pediatric patients. What do you think about the one key question or the path question, and how might that be in your practice, the value, etc.? Radio silence. Right. So these are probably not questions to ask with the parents, especially if you want to get an accurate understanding of, if the parents are there, they're going to say they're not interested in getting pregnant, right? So these are questions I would ask when you're having that confidential conversation. What age should we start? Oh, should we start asking these questions? You know what? I recommend that you start asking these questions after she's had her period. There's not really an age. It's going to be as soon as she has the potential to have a pregnancy. Yes. So again, the time issue, right? And so I can't fix the time issue. I do think the pregnancy intention one key question is so short that you can absolutely, and someone wrote that their MAs are asking the one key question during grooming, or you could, if you have an adolescent questionnaire, that could be so easily added to that questionnaire. I knew someone was going to ask about the one key question, wants to get pregnant and they are a young adolescent. Okay, so that's like the one that's the worst. That's the hard one, right? What I'm going to say to you is, when this happens to you, first of all, you're probably going to like flush and have like sweatiness and like feel really ill. But also, And you're going to have a strong, like, kind of moral, ethical response to this from your own set of your own morals and ethics. But on the other hand, how amazing that you understand this about that young person. Okay, so I don't have and we're not going to, when I was a fellow and resident, it was kind of the scare them straight approach, right? Like, tell them how awful it is to have a baby, tell them a little about how it's going to ruin their life. That is not a recommended approach any longer. The approach that's recommended is really aligning yourself with your patient, understanding the world that she lives in, developing that relationship. So I'm going to think the 12 or 13-year-old who says they want to get pregnant in the next year. So amazing that they or she were honest with you. You're going to have some rapport with them. That's someone I would want to have come back frequently. I'd probably want to do an ACEs screen and kind of really understand their world. You might talk about getting them on prenatals and maybe come up with a reason about, like, it's going to make your hair stronger and things like this. This is how you can talk about being on a prenatal vitamin. That's probably a hard thing to do for most young people, but I think someone like that you're going to want to keep close and really probably see often to make sure that she's doing okay. It also makes me concerned that she's either being trafficked or has been or is being sexually abused, because most young adolescents do not have a positive pregnancy intention, so it's a red flag. Let's see, anything else to talk about? Okay, so many, lots of different responses, mostly positive, and this was new to me probably 3 or 4 years ago, and it has made a big difference to my practice, so I hope that something here is useful for you. Let's go to the next slide. Okay, I think we've covered some of this, but how are these approaches different than what you use? So what do you use right now, and how is this different? Heads. And this can go so well with heads. I use this with heads. So I am pro heads. And I put this in when I'm in the S part of the heads doing sexual history. So I do gender identity assessment, I do sexual activity, kind of body parts, genders of partners, and I do pregnancy intention. All right, let's move on. So we've had some comments in the previous slide about what you like, and they really, the themes that I recall are really kind of aligning with your patient, having them feel heard and understood. Anyone else have some things they like about this approach? All right, we're going to go on. I think we got such a robust response in the first time. And then what might be hard? So we heard kind of conversations with having the parent around. That's not going to work very well. So these need to be done ideally in a confidential setting. Time, but I'm going to encourage you to think about having a workflow that might incorporate that one key question with a questionnaire, MA, or even yourself asking it. It's just one question. Any other thoughts on what might be hard? Oh gosh, yes. If the patient says she wants to get pregnant, then how do I talk to the parent? So really, I'm gonna share about the parents. So, the conversations that you are having, especially if the parent has assented to you having this conversation, that has protected that conversation. We are, mandatory reporters and legally compelled to share if a patient is being abused, or we have serious risks about their health or their well-being. But I would not include a positive pregnancy intention as something that you are compelled to share. And it's probably a relationship ender with the kid. So unless there's other things that are kind of more compelling in terms of safety, I would not think you are compelled to share this information. I might, and a young person is not going to want to share this. This is like coming out of like the most private part of herself. So I would encourage, you to continue seeing the patient and having private conversations with this patient. Gosh, so much. So the parent who does not want to leave the room. Okay, I'm going to tell you that. I call that the stinker. Everyone has these stinkers. And what I do when I have a stinker is just say, okay, I understand. We are going to just do this conversation with the parent in the room. So I basically ask the same heads questions or the sexual history questions. I don't go into all the detail about body parts, etc. But I ask the questions, and then I put in my note, right, parent was present when I asked the question. So I don't know if I really believe them, but I think it helps demystify that conversation for the parent who is mistrustful and doesn't feel comfortable with you having that conversation with them. If the parent really feels like this is not the practice for me, well then it really just might not be a good match. On the side of the patient, I think the patient then does know that these are the kind of issues that you care about and they can talk with you about. If I have a situation where I really do have a safety concern and I can't get the kid alone, then we can kind of come up with a reason to, maybe we have to check a vital sign again or check the weight or have the kid go to the bathroom, get a urine sample. Like if I really have a safety concern, then we will find a way to talk to the young person one-on-one. And I do think there is value in including parents, absolutely, in discussions about sexuality, particularly when the adolescent is comfortable with that. Let's see. I think we're going to go on in the interest of time, but Joe, I don't know if we can take a screenshot or capture these if we want to kind of, or if we didn't get to them, throw them in the Q&A when we get there later. Let's see. I'm going to just say, issues with the interpreter, yes. Oh, the portal, the 21st century cures, right? Oh, God. Okay, and Joe's going to place in the queue. So we'll get back to as many of these as we can later. Okay, so in this process, we have aligned with the patient. We have tried to understand the pregnancy intention of the patient. And I'm going to tell you, I know we're in the chat, there's a lot of alarm here. I'm going to tell you 95% of the time it's going to be no. It's going to be no. And then you're going to just have this really excellent opportunity to align with your patient, okay? So the next thing that's new, so this is part of like what's new about contraceptive counseling, is really eliciting the patient's preferences. So a couple ways to do this. One way, and these are from Patty Kaysen, so one way to ask that is, once you're into a conversation about birth control, do you have a sense of what is or might be important to you about your birth control method, right? Do you have a sense of what you're looking for in a contraceptive method? So I want to tell you here that the answers are not here. This is really cutting edge stuff, and the world of pediatrics has not solved this problem because this works well in older patients who are sexually experienced, who've used contraceptive methods, who understand their periods. These questions don't work very well in young patients. So what it means with young patients is you might want to explain a little bit about what you mean. You might say, we've got some different treatments that have different effects. One option is we can really reduce your experience with bleeding and periods. Another option, another set of treatments, helps you have a really regular, predictable period. Which of those sounds like might be your preference? So I do think for younger and middle adolescents, giving them a sense of what might be preferences is helpful, but this is not an area that has been well researched in adolescents. So, but it's important to do it if you can. For example, if they have cramps, are you interested in an option that's really going to help with your cramps? Great, now you're going to know that. All right. Alternatively, this is currently the recommended approach from the American Academy of Pediatrics. So in 2014, they endorsed efficacy-based counseling. So efficacy-based counseling is you present your patient, and ideally with a little handout or a menu, and you talk about options in the order of how effective they are to prevent pregnancy. What we know about women and young people is the most valuable priority is actually how well it works to prevent pregnancy. So if it's your preference and you'd rather just skip to that, that is okay. And you can use a method, or this is a sheet from Bedsider, which is a nice, has some wonderful reference materials, and you can go through options kind of in order of effectiveness. So I'm going to share with you, I'm going to review what I just said. So in terms of providing information about contraceptive options, you can provide brief information about contraceptives from high to low efficacy. And again, it's going to be really nice if you have a menu or something to review. Alternatively, the new thing we talked about, and this is again, this is new for pediatrics, and it has not been endorsed as a policy statement yet by the AAP, but it probably will be soon, or it will be, this is emerging in the world of family planning as the approach, is to discuss and educate about specific method-related preferences. So I'm going to just leave you with that. And please know that if you are doing efficacy-based counseling and starting at the most effective and going to least effective, that is a fine way to do it. But it can really, really help to understand your patient's preferences. For example, if your patient tells you that that it's really, really important to her to have a regular period, and that's like her highest preference, you may really not need to spend time talking about all the methods in which she is going to have an unpredictable period. As an example, Depo-Provera and the hormonal implant have known side effects of very unpredictable bleeding, right? So someone who wants a predictable period, you may really focus on the methods that are most aligned with her preferences, which in that scenario would be oral contraceptive pills and a patch and a ring. And that can save some time if you just focus on her preferences and the methods that are aligned with her preferences. All right, so earlier in our talk, we had some folks talk about how they wanted to understand how to start a method. So I'm going to take you through what I think is really most important around starting a method. So number one, you need to think about, are you reasonably certain she's not pregnant? I'm going to take you through these points in slides. Number two, you're going to review the contraindications. And then number three, you're going to provide that method, you're going to refer or do a bridge method. So these are really, when I'm training my fellows and my residents, 1, 2, 3, this is how I think through it. So how can you be reasonably certain that she is not pregnant? So the best way to do this is to ask about the timing of her last menstrual period and unprotected intercourse or contraception use essentially since her last period. So this does mean you need to get in the nitty-gritty of asking about kind of sexual encounters and if they were protected or not within the timing of her last period. So this is from the Centers for Disease Control, and this is, I just think it's gold. So you can be reasonably certain that a woman is not pregnant if she has no signs and symptoms of pregnancy and any of the following, and I'm just going to go over the top 3 bullets. If she's within 7 days after the start of a normal period, end of story. You can be reasonably certain she's not pregnant. Also, if she has not had sexual intercourse since the start of her last normal period, you can be reasonably certain she's not pregnant. And if she's been correctly and consistently using a reliable method of contraception, regardless of when her period was, you can be reasonably certain that she is not pregnant. So I'm going to show you later in the talk how to get this content really handy. You can print it out, put it on your wall, have it on your phone. But if she meets any of these criteria, you can be reasonably certain that she is not pregnant and can feel comfortable moving forward with contraception care. There was a paper that was published in 2015 that looked at using these criteria and then adding a negative office urine HCG test, and the negative predictive value was greater than 99%. So if you use the questions and add a urine HCG, a negative is going to be more than 99% predictive. But adding an HCG is not required, because as you recall from the previous slide, there was no urine pregnancy test in that list. So this is the app that I really hope that you all consider downloading or sit and do it right now. You can go to the Google Store, the Play Store, or the App Store, and you're just going to put in the search term CDC and contraception. And this is the app that's made by the CDC. It's updated regularly. It is wonderful. And as you can see on the slide, it has select practice recommendations is what you're going to pick. And then you are going to see under SPR how to be reasonably certain that a woman is not pregnant. So if you don't remember the things we talked about on the slide, a couple previous, I hope you do download this app and just have that really handy to know how to be reasonably certain a woman is not pregnant. And the good news is, so first of all, if you're reasonably certain she's not pregnant, you can start a contraceptive method then. However, I'm going to share this with you. This is according to the CDC. Even in situations in which a healthcare provider is not reasonably certain a person is not pregnant, the benefits of administering the contraception that day, except IUDs, generally outweigh the risk, as none of the contraceptive methods are known to be teratogenic or abortifacient. And then the recommendation is if you're starting when you're not reasonably certain she's not pregnant, then you're going to recommend condoms or abstain until the next period and a urine pregnancy test in 2 to 4 weeks. So I'm going to give you an example of when this might be the case. Say you have a patient who's coming in and she wants to start birth control pills. You do a sexual history and she essentially tells you she's had a sexual marathon for the last 10 days and she's had sex every day. In addition to thinking about emergency contraception, you can feel comfortable, and you're not reasonably certain she's not pregnant, right? Because she's had a ton of sex. And let's say her last period was 3 weeks ago. However, what the CDC is saying is that the benefit generally outweighs the risk to go ahead and start the method. And then you're going to let her know that if she doesn't have her period on the withdrawal, then let you know, and also to do a home pregnancy test in 2 to 4 weeks. So again, I'm sharing this with you, not because I'm kind of an out there doc. These are really our CDC recommendations, and it's really how can we help women and young people get started on the methods that are going to help them and not introduce barriers to getting started. And you probably have stories, and I have stories as well, about women who've had barriers and then pregnant. So assessing medical eligibility, that's something that came up earlier as well. So the CDC app, again, is going to be probably your best reference for that, and that's under the tab MEC. But I want to tell you the statement that I came up with when I was designing a contraception guideline for our institution. A healthy young person with no active or previous medical conditions, who takes no medications or supplements, can safely use any reversible contraceptive method. So essentially, if you have a healthy young person, she can use any reversible contraceptive method. Safe provision of contraception relies largely on history and rarely requires a physical exam, pelvic or breast examination, STI testing, or cervical cancer screening. So we had talked a little earlier about pelvic exams. So again, pelvic exam is not required to start contraception care. And then using contraception is very safe and is safer than pregnancy for young people and for women. So much of the information can be obtained from the patient history, including patient-reported or previously reported blood pressure for telehealth. So if you're doing a telehealth visit, you can use previously reported blood pressure if you want to make sure that she does not have high blood pressure prior to starting a combination hormonal contraceptive. And then the U.S. medical eligibility criteria, which is in the app I told you about, provides guidance on contraindications to contraceptives based on the patient's history and is available in many forms, including the smartphone app as well. So this is what the smartphone app looks like. So you can see if you select MEC by condition or method, If you select by method, you can see you can tab through all of these methods here, and if you click on one, it's going to take you to a page which is going to list the contraindications. You can also go to the website for the CDC, and it's right here, and I have I literally have one right here. So I have these in my office, we have these in our resident workroom, so we have these little pieces of paper that have tables and that we reference all the time. So you're thinking, is this anti-epileptic medication okay? Is this antibiotic okay? What if she has lupus? All of this stuff is going to be in the CDC medical eligibility criteria app, and then hopefully it's going to help you feel safer about prescribing contraceptives in the office. And this is the kind of the rubric that the CDC and the World Health Organization use. So green on the app or the chart basically is a green light, it's a go-ahead. Category 1 says no restriction, and category 2 is that advantages outweigh the theoretical or proven risk. So anything that's green, you should feel really comfortable prescribing from a medical contraindication perspective. Something that's a category 3, it's going to be like kind of a yellowy orange color. In those circumstances, the guidance is that the theoretical or proven risks usually outweigh the advantages, but it's not a stop. Number 4 is a hard stop, and that's saying that the risk is unacceptable to prescribe the method with this specific health condition. And as an example from earlier in the conversation, a migraine with aura is a category 4 contraindication for combination hormonal contraceptive use. So as an example. All right, so moving along to contraceptive provision. So at this point, hopefully, you're reasonably certain she's not pregnant and you've reviewed the medical contraindications. And hopefully, those are both lining up so that you're reasonably certain she's not pregnant and there are no contraindications. And then providing the contraceptive. And sometimes the method that a patient wants does not align with medical eligibility. And in those circumstances, that's again where more shared decision-making comes into play, and you share with the patient that said method is not recommended for her to use and why, and then talk about the alternatives so you can come to a common ground. So ideally, you're going to provide the method of choice at that visit, and that's consistent with guidance from the American Academy of Pediatrics and the American Congress of Obstetricians and Gynecologists. So we really want to encourage folks to provide the method the patient wants at the visit. However, if you are unable to provide, there's a couple things that are recommended. You can schedule a return visit at earliest convenience for the patient to come back, either for more contraceptive counseling or for provision. You can refer to another clinician who can get the job done. So bedsider.org is a nice website that's run by the group that was formerly called the National Campaign to Prevent Teenage Pregnancy, something like that. But this is a nice website that lists family planning providers. So as an example, my clinic is listed on bedsider.org, and people across the world can locate clinics based on the information in Bedsider. Number 3, if you can't provide the method that they want, say you have a patient who wants an IUD or an implant or depot, and you are unable to provide those at the office, the recommendation is that you provide what we're calling a bridging contraceptive. And this essentially means something that's acceptable to the patient. It's generally a shorter acting method, but it's going to help them bridge to their appointment to get their ideal method and help prevent an unintended pregnancy in the time between those appointments. And I don't need to tell you that it's not uncommon for persons to get pregnant while they're waiting for a contraceptive. So really you want to help provide that method provide a bridging method while they're waiting. So as I mentioned, a bridging contraceptive is a short-term method to bridge the patient to her first choice method when that method is unavailable at the time of counseling. And usually this is going to be a pill, patch, ring, or injection. If you have uncertainty about using an estrogen-containing product because of a medical contraindication, the method I told you about earlier, that SLIND, is a nice option. This is a progestin-only pill. It's easy to take. It's a daily method, and it really could help her get from point A to point B and not be pregnant. As well, the standard mini pill is a great option there too. Emergency contraception. There's a lot to say here, but I just wanted to share with you some updates, and I want to keep this at least alive in your mind, that emergency contraception is important. So the levonorgestrel IUD and the copper IUD are the most effective emergency contraceptives. Counseling patients about using emergency contraception pills and offering an advanced prescription may be particularly beneficial now in COVID because of access barriers and to reduce cost. And then ulipristal acetate, which is sold as Ella in this country, is actually more effective than levonorgestrel emergency contraception. Levonorgestrel emergency contraception is sold as Plan B or Next Choice, but ulipristal acetate, which is sold as Ella, is more effective, particularly at higher body mass indexes and for patients who have sex more than 72 hours. It does require a prescription, but I want you to remember the importance of thinking about Ella. And then patients who take ulipristal acetate or Ella for emergency contraception should wait 5 days to take a hormonal contraceptive because of medication interactions, and then use condoms until their next period. All right. So if there are no contraindications, the patient can proceed with the contraceptive of choice. So you can prescribe pills, patch, ring, recommending same-day start, and then recommending 3-month supply if the insurances will cover that, or a 12-month supply. But what we are doing now is 3-month supply with 4 refills. We're not having a problem, and I think it's because of COVID with getting that filled. If they want Depo, a Nexplanon or IUD, you can schedule that visit or place the referral if you don't do it yourself. Consider starting a bridging contraceptive that if the same day start is not possible, and then counseling about consistent condom use. Consider prescribing emergency contraception, and then scheduling or discussing any necessary follow-ups. And then some additional considerations. It's really helpful to provide written patient information, and you can access some information on the references at the end of the slides. Encouraging consistent condom use for the prevention of sexually transmitted infections is very, very important. And maintaining open lines of communication. So with every patient I see, I want her and her caregiver or mom to know that if they're having problems getting the medication, taking the medication, with side effects of the medication, that I want to know about it. And it's important to communicate with your patient how they can let you know about their concerns, whether that's using a patient portal or calling the office. So in summary, she's made a decision that you've helped her with using shared decision making. You are reasonably certain she is not pregnant, and there are no contraindications to her chosen method. And you provide the chosen method or return later / referral to a contraceptive provider with consideration of a bridging method. And then she knows how to contact you with any problems. So thank you so much. I'm going to scroll through just the reference slides so you can see them, and then we'll take questions. And here's the practice change that I came up with for you. I hope, this is what I want after this lecture, is that that you are sure that every young person at risk for unintended pregnancy who wants to start birth control leaves your office with a contraceptive or a plan for contraception. And I think that is it. Joe?
All right, at least we will get through as many questions as we can. One that came up is, can rings stay in if an adolescent is being treated for an STI like gonorrhea or chlamydia?
Yes.
Oh, good. All right, that was fast. Wait, give me a minute. Is IUD for heavy menstrual bleeding in a patient who's never been sexually active?
Yes.
Okay.
Yes. So the IUD is the most effective treatment for heavy menstrual bleeding. And the levonorgestrel IUDs at 52 milligrams reduce bleeding by 90%. So they're a great option. I do talk about this at length in the pre-recorded session I do on this. It's not the best treatment in the acute setting. So in the acute setting, you're going to use most of the time some type of pill to control the bleeding. But in the middle to long term, even for patients who've not been sexually active, if you have good adolescent medicine or good gynecology who can really help a patient through the procedure, they may be able to do an in-office procedure. Some sites are offering placements under sedation or in the operating room for patients who either don't think they can tolerate an exam, have special needs, or have a history of trauma. So it's probably good for you to identify the resources in your community, but absolutely it's a thing.
So it's interesting, it's kind of in children with special needs, like for instance, children who are autistic or have some kind of intellectual disability, or VP shunt and have kind of difficulty with menstrual hygiene or not sexually active. What are the options for contraceptives in those patient populations?
Yeah, so depending on the specific medical eligibility, we often move away from estrogen-containing contraceptives for those kiddos. And this is where I thought you were going at the beginning of the question. So a levonorgestrel 52 milligram hormonal IUD is a great option for women with cognitive limitations and special healthcare needs who have problems with menstrual hygiene and or irregular bleeding or cramps or other menstrual issues. You're going to need to have someone who can place the IUD under sedation, but a lot of times if you have a children's hospital near you, if the patient is having another procedure, sometimes our gynecologist can go in during another procedure and perform the procedure. Depo-Provera is a great option for menstrual suppression as well. And we are also using norethindrone acetate, which is agestin for our patients who don't have contraceptive needs for very, very effective menstrual suppression, usually at 5 milligram daily dosing.
You kind of alluded to this earlier when kind of talking to adolescents and their kind of intentions to get pregnant, or even with regard to sexual activity and including that in your notes. How do you handle situations where the parents have access to the adolescent's medical record?
I know.
Have access to the portal? I mean,
that's a whole talk, right? First, there are the issues with the portal, and then there's the issues with 21st Century Cures Act that we're all struggling with, to be quite honest. So you don't want to include that sensitive information in a parent-facing document. That's really going to compromise the adolescent's sense of privacy and potentially your relationship with that patient, and could put that patient at risk of harm from her caregiver. So the best thing to do would be to sort through with your institution how you can make a sensitive note, depending on, I think that's what most institutions are doing. Epic has a functionality at my institution. We're putting kind of that type of sensitive content. We're essentially making another note and marking it sensitive, and making sure we put the sensitive content there. And then we put a little phrase that says, because of concern for patient harm, we are protecting this information. But I think this is very much an evolving situation. I hope it's going to change. And there's a whole, maybe next year I'll do a talk on consent and confidentiality, but it's a challenge.
What emergency contraceptive method do you think about or use in patients with migraine with aura? So
all of the emergency contraceptive methods that are branded that way, such as Plan B, Ella, do not have any estrogen in them. So there are no contraindications for migraine with aura or any of the estrogen contraindications. And kind of the big picture as well is that that patient is going to be at an increased risk of blood clots in a state of pregnancy, much more than using even an oral contraceptive. But to answer the question, any emergency contraceptive is acceptable and safe.
How often do you follow up on adolescents' birth control with regard to whether or not they're on pills or patch or rings? What's your recommended follow-up for these patients?
So most of the time in my practice, I'm going to do a 3-month follow-up. It is recommended to provide a whole year's worth of supply, but I like to have them come back in 3 months to check side effects, adherence, and if there's any kind of gynecologic benefit that we're trying to get. With an implant, really, there's no need for a follow-up other than if there's some gynecologic issues. And then IUDs are 6 to 8 weeks standardly for an IUD check.
One last quick question, perhaps. Any blood tests needed prior to starting OCPs or ultrasound of the uterus and ovaries needed?
No.
Okay. All right, that is it. We are at time. Dr. Berlin, thank you. That was a fabulous talk. What a great update on adolescent contraception. I've learned a ton that I'm going to have to bring back to my house staff and my residents. So thank you so much.
Wonderful. Thank you so much for inviting me. It's been a pleasure. Bye.
All right, all, thank you for hanging in there. We are at the end of the session now. And again, once again, thanks to Dr. Berlin and thanks to all our speakers. And thank you all for your participation. It is great questions as well. We will be back at 10 o'clock Central Standard Time tomorrow morning for our next session. That will start our Q&A session with our next group of speakers. So if you think of any questions for that next group of speakers, please go ahead and either put them in now or put them in the morning. Enjoy the rest of your afternoon and evening, and we will see you tomorrow. Thank you.